So today I'm going to talk about some work that we've been doing across the Pacific Islands on integrated serological surveillance on a whole range of different infectious diseases in multiple countries in the region. So these are the things I'm going to focus on today. So talking just generally about what integrated serological surveillance means and how that can be useful for informing public health action and decisions, and some examples of work that the Odyssey team has been doing in the Pacific. So Odyssey is the name of our group. It stands for Operational Research and Decision Support for Infectious Diseases. And also the discussions that are happening now about the potential to actually embed integrated serological surveillance as a routine activity into ministries of health and into disease surveillance, moving beyond it just being a research tool. And then finally, some regional discussions about collaborations and coordination across the Pacific region. So firstly, what is serological surveillance? Some of you would already be quite familiar with that. For those of you who are not, it's population-based surveillance to detect antibodies against pathogens. So some studies would just be looking at one pathogen, some could be looking at multiple pathogens, and we're doing this to estimate the prevalence of these antibodies at a population level. So that could be national, subnational, or specific populations to help us understand the epidemiology of a particular disease or diseases that we're looking at. So this is very different to other types of surveillance, like case-based surveillance, where people are notifying cases, hospitalizations, deaths. This is really typically serological surveillance is on populations that are healthy, so population representative in healthy individuals. It's also very different to syndromic surveillance, where we're looking at syndrome, so constellations of signs and symptoms that make up a syndrome. This is serological surveillance, where we're looking at antibodies in people's blood. So what can serological surveillance tell us? There's a whole range of things. I won't go through all of them, but for example, for diseases like measles, it will tell us what the population immunity is in your study population. So this immunity can come from infection or from vaccination. And usually with things like measles, once you have been infected, generally you're protected for life. Also from vaccination, generally protected for life. But in other diseases, the presence of antibodies might indicate current infection. So the chronic infections like hepatitis B, HIV, you might still have current infection. And measuring antibodies can also be useful for looking at progress towards elimination targets, or in situations where where countries have already reached elimination targets, whether they're managing to maintain those targets. Then if we combine the antibody data with things like geographic information systems data, environmental data, GPS locations of where you've collected the data, you can do other things like look at hotspots and do spatial epidemiological studies. And if we do multiple studies over time, we can also track what might be happening over time, either just as a result of changes over time, but also looking at actual events or interventions and what's happened before, what was before and what's happened after. So these interventions can be things like vaccination programs, mass drug administration programs, or after an outbreak or some other event. And then more sort of slowly, there are things like the impact of climate change on infectious diseases. We can look at that over time, but that's like a more slowly progressing thing. So vaccine preventable diseases are a big problem in the Pacific. So this is really of major interest in the region. And there's a lot of very granular data that we can potentially get about vaccine preventable diseases. So population immunity, but assessing, like I said, impact of interventions like outbreaks, catch-up programs. But we can sometimes also uncover undetected transmissions. I'll show you an example of that later on. So I'm just thinking that you guys here might not be able to see half the screen. So please feel free to move, and I won't be disrupted. And we can also look at age-specific seroprevalence that might sometimes be useful for informing decisions related to vaccination programs, like dengue vaccination programs, for example. And sometimes measuring antibodies in blood can give us a more accurate estimate of population immunity compared to vaccination records. So the records sometimes are based on just people's memory, and they might not be accurate, or the like electronic records might or might not be accurate. But beyond that, sometimes there are cold chain issues. So even though someone's been given the vaccine, it might not have worked, or they might have responded to it, and also immunity might wane over time. So if we're measuring it on the spot, we actually know whether people are immune or not. Okay, so that's just serological surveillance in general, which can be done on one disease or multiple. Integrated serological surveillance, or sometimes just called serosurveillance, is an emerging approach where we can test for multiple pathogens at the same time on quite small blood samples. So the WHO definition of this is the implementation of population-based surveys to collect and analyze samples for simultaneous estimation of seroprevalence to multiple pathogens. Bit of a mouthful, but basically it means we can test the blood sample at the same time for multiple different things. And one of the ways in which people have been able to make this happen is to use these multiplex bead immunoassays. And I won't go into the technicalities of that. You can have a read about that. The two most common platforms are the Luminex or the Bioplex platforms. And you really can detect antibodies to, hundreds of indicators. But typically, we're a little bit more specific and think about what it is that we want to know and pick out the diseases that we want to look at. And usually this is done in consultation with countries, with ministries, and we focus usually on about 20 or so things. And so if you can imagine, this could potentially be a very cost-effective way of generating very detailed epidemiological data for multiple diseases. And for countries that have, challenges with resources and human resources as well, this is quite an attractive option. So I'm just going to show some examples of work that our team has done in the Pacific Islands, in Samoa, in Tonga, and in Niue. I'm not sure how many people here have even heard of the country Niue. It's a tiny country in the South Pacific with around 1,000 people. And it's very difficult to get to, but in places like that, you can essentially do a census survey where you can, test pretty much everybody. Anyway, so these are, studies that quite different studies, but all of them have included integrated serial surveillance using these multiplex bead assays that we've done over some years. So starting with Samoa, in 2018, we did a study for lymphatic filariasis, which is a parasitic infection and neglected tropical disease. And the survey was designed to assess the impacts of a mass drug administration for lymphatic filariasis using these rapid diagnostic tests that don't look too different to COVID rat tests, but blood instead of swabs. But at the same time, we collected these dried blood spots. So these are filter papers. We put, 10 microliters on each of those ears on the filter paper, and all the tests were run on just one or two of those ears, and then the rest is stored. So we're talking about tiny blood samples here. So on your right, I'm not going to go through in any detail, but you can see some of the diseases that we included for this serological surveillance, which included neglected tropical diseases, some vaccine-preventable diseases, and arboviruses, which are a huge problem in the region. So dengue, 1, 2, 3, 4, Zika, chikungunya. And here's an example of how this might have been useful for informing public health action. Now, this survey was done in 2018. Back then, the processing of the lab samples was still at a very early research stage, done at the US CDC laboratory in Atlanta. And it took almost 3 years for us to get the results. So it was really a research thing, 3 years, it's not really that useful for informing any public health action. But if we look back in time, if we had got these results in good time, you can see that measles seroprevalence was only about 50%. And we need it to be at least 95% to not have a measles outbreak, because measles is so transmissible. So if we had this information at the time, we could have told the ministry, you're at high risk of a large measles outbreak, which actually happened in November 2019. So the very large outbreak, many thousands of cases, and I think around 80 or so deaths, one of the largest recent outbreaks in the South Pacific, which also spread to some of the other countries. The good news is we have now more recently collaborated with a laboratory in Melbourne, the Burnett Institute, who are processing our samples in about 2 or 3 months, which means, the results are much more usable. So just digging a little bit more deeply into the measles seroprevalence data in Samoa. So this is 2018, 2019, before the outbreak. And you can see there's quite a big difference in immunity by age groups. So if you had this information at the time in the ministry, okay, who do we need to target for vaccination? It's the people under 40. People over 40 probably are all infected as children in this population. And then this is what happened after the outbreak. So from a combination of infection, vaccination campaign, 95% plus immunity in all age groups. So you can see that these assays actually work. They're telling you a story that you're expecting, because measles is so infectious that anyone who's not immune probably would have gotten infected. Now, this is rubella, and similarly in 2023, very high immunity from the catch-up campaign most likely, and then before that, lower immunity, but not as bad as measles. But the interesting thing is, if you focus on the top graph, see there's quite a big gap between the orange line, which is measles immunity, and the blue line, which is rubella immunity. And measles and rubella vaccines are given together as MMR, measles, mumps, rubella, like what we use here. So why do we see that big gap? The most likely explanation is that there was local transmission of rubella that was undetected. So rubella generally is much milder than measles. People don't get as sick, and it might just go undetected, maybe even asymptomatic, or a mild rash that has disappeared. But the important thing about rubella is congenital rubella syndrome. So if a woman is pregnant and she gets rubella, the baby or the fetus can develop some very severe developmental things. And in a country where the congenital rubella surveillance is not that strong, that can very easily be missed. So in 2023, which is the graph below, you can see, that gap has closed, but pre-outbreak, almost certainly we had rubella transmission. So these are really important insights. And even though 2023, we're looking at, really good immunity against both measles and rubella for all age groups, this is now 3 years ago, and the outbreak happened in 2019. So if you don't maintain good vaccination coverage, it will slowly drop back to, where you were before. Anyway, so that's generated some very useful information for Samoa, and we'll be going back there later this year to do another survey, this time funded for specifically vaccine-preventable diseases rather than lymphatic filariasis, but we will also test the samples for lymphatic filariasis to generate information for NTD. So in this climate of global health funding, I guess, wherever we can find funding to do the primary study, we can still slot in collection of samples that we can use to test for a whole range of other things. So moving on to Tonga, this is a study that we did in 2024. So the global program to eliminate lymphatic filariasis is one of the largest public health programs in the world. And many countries in the Pacific have reached elimination targets. So 8 of the 16 endemic countries have reached targets, the other 8 have not. And Tonga reached targets in 2017, but had not done any post-validation surveillance until this study. So this was a targeted study going back to look at the previous hotspots and in communities and in particular islands. But at the same time, we also collected these dry blood spots to test for a whole range of other things to make the survey more valuable for the country. And so this was a collaboration between the Ministry of Health, our group, and the Burnett Institute, and again, using multiplex bead assays. So the paper's just been accepted last week if people want to have a look at it, but there's a preprint there. And just a very quick rundown of the types of insights you can get. So all of these results are just from the dry blood spots. So the different blocks of bars are for different NTDs, neglected tropical diseases. And we won't go into all the details here. And the different colors are for the different island groups. So as you can see, the seroprevalence for different NTDs varied quite a lot, even by island groups within quite a small country. Tonga has a population of 100,000 or so. So, you know, really there's a lot of variation. And knowing this information will help you target your public health interventions, design your public health programs, etc. These are arboviruses. So again, each block is a different arbovirus, dengue 1, 2, 3, 4, chikungunya, Zika, and each color is a different age group. So you can look at things by location, by age group, and this will be important for informing dengue vaccination recommendations. However, they've just had another dengue outbreak, so this is probably going to look very different right now. And also by sex. So most of these vaccine preventable diseases about the same seroprevalence for males and females, but for the ones that are different, the males have lower seroprevalence, which is not atypical. A lot of the times, males are less likely to go see the doctors, get vaccinated, etc., compared to females. Okay, so that's just a quick sort of overview of Tonga. This is another example in Niue, that tiny country, where we linked this integrated serological surveillance with a non-communicable diseases survey. So we don't need to limit ourselves just to infectious diseases when we're integrating these activities. And when we talk about integration, it's not only at the lab testing stage where we can integrate, we can also integrate at the sample collection stage, because that's actually the bit that's the most challenging logistically and costs lots of money. So the stepwise survey is a survey for non-communicable diseases they do across many countries every few years, and people get their highs and their weight and blood pressure and have a finger prick blood sample to test for blood sugar and cholesterol. So our team hooked onto that and collected a bit more blood, made dry blood spots to test for all of these things. So don't worry about all the details, but the yellow bits on top is what the STEP survey normally does, and the blue bits is where we integrate it. Collection of questionnaire data, collection of blood sample, etc. And if anybody, the formatting got a bit messed up there. Maybe not. If anybody wants to have a read, there's a paper down here. But the big message here is that it saved so much money and effort. So they integrated the WHO STEP survey with lymphatic filariasis rapid antigen testing with dry blood spot collection and a mosquito survey. And overall, it costs about half compared to doing, each of those things individually. So really important in terms of resource saving. Okay, so those are just a few examples of studies. We have a few more that are happening this year across the Pacific. But also want to just share that we're involved in a few regional initiatives that would be great, for the Centre of Tropical Health and Emerging Diseases to be also part of. Some regional initiatives to try and advance this integrated serosurveillance approach. So last year we ran a meeting called a Voices and Visions meeting, where we had people from about 15 Pacific Island countries and territories to talk about how we can make this work. And it's actually led to funding for more work and elevation of this approach to the Pacific Public Health Surveillance Network, and hopefully we'll get some traction. So we're trying to hold another meeting later this year to continue these discussions, maybe in October. We're having challenges with finding sponsorship, so we'll see how we go with that. And the Burnett Institute, which is where we've been sending our samples recently, have set up a network called SeroPac. And the idea of this is to try and bring different partners from across the region together to advance this approach. And so it includes laboratory, public health capacity building, the standardization of assays across the region, as well as analyses and research translation and scaling up in the region. So Leanne Robinson and Fiona Anguissano at Burnett are driving this, but I think there's potentially opportunity for us to get Brisbane labs involved in the SeroPac activities. And then more specifically for lymphatic filariasis, I don't know if any of you are familiar with PACALV. In the early days, the Pacific program to eliminate lymphatic filariasis, that provided a lot of technical support to countries in the Pacific for LF elimination. But that's stopped now, and countries are now starting to require this support again because either they can't reach elimination targets or they have already been validated, but now they're facing problems with resurgence. So we're talking to various groups, including WHO, about whether there's a place for reviving something like this. And just to finish off, what do we need to scale up serosurveillance to be a routine activity? So firstly, we need political buy-in, country buy-in, to embed this into the routine system. Funding to make that work, as well as funding for the surveys, collect samples, etc. The laboratory testing, which is what SeroPac is trying to set up. Now, most countries are not really necessarily that interested in setting up their own testing capacity for this kind of thing, because you only do it so intermittently. They're more interested in the results. So I think, just because you can't set up the lab in country, it doesn't mean that, people can't do it. And then, of course, the standardization related data analysis and interpretation and regional coordination. Okay, so the takeaway messages is that it's really a cost-effective and potentially a sustainable approach once, the systems have been established. And we have already demonstrated the feasibility and utility of this approach for multiple diseases in the region, multiple countries. Now it's just the logistics of how to make that work and how to, fund it and how to get buy-in, and then a regional leadership to support this. So apart from SeroPac, SPC, that's the Pacific community, is also super interested in this, and they've funded some of our team's work this year in a few countries in the Pacific. And so we're just, trying to talk to the regional leaders in this space to try and get this happening. And that's it. This is our team, well, most of our team. This was taken in October last year, and we've had quite a few new students and other team members since then. And if anyone's interested in having some more discussions about potential collaborations, please feel free to contact me. Thank you very much.